Hello and welcome back to another episode of the Newbie Dentist podcast. I'm your host, Dr. Omid Izami. It's been a few weeks since the last episode, so I do apologize for the long gap. I have a lot of great interviews coming up over the next few weeks, and I'm excited to be sharing them with you. I've been getting a lot of messages lately from dentists from around the world, and I must say I really do sincerely appreciate the kind words, and it really does give me the motivation to continue to put together these great interviews for you guys, the listeners. In this week's episode, I had the great opportunity to sit down with two of Australia's premier endodontists, Dr. Mehdi Rahimi and Dr. Mark Johnstone. Dr. Mehdi Rahimi is an endodontist based in Sydney, Australia. He is an adjunct associate professor at Charles Sturt University and is involved in endodontic continuing education programs and teaching at various levels, both throughout Australia and abroad. Dr. Mark Johnstone is an endodontist based in Melbourne and is also involved in teaching in continuing education programs with Dr. Mehdi Rahimi, and they run a lot of great courses, which I was actually lucky enough to attend. Mark just recently completed his Master's of Health and Medical Law as well at the University of Melbourne, and Mark was actually completing his endo postgrad while I was a dental student at the University of Melbourne, and I had the great opportunity to learn from him as he was one of my endo demonstrators in dental school. In this interview, we cover a lot of great topics, including the importance of mentors, whether or not to specialize in endodontics in 2019, emerging trends in endodontics, staying out of trouble with a solid informed consent process, and much, much more. This episode is brought to you by my good friends at Henry Schein Australia. With over 60,000 products available from consumables, CAD/CAM technology, lab equipment, and continuing education courses, you can always rely on them to be your trusted business partner every step of the way. If you haven't already, be sure to check out Foresight Dental, that's the number 4, SIGHT Dental, on Instagram and Facebook. Foresight is a collaborative project between myself and Dr. David Kier, and we've put this together, and we're actually putting on the final touches on our Foresight Dental Journal, which we'll announce pre-sales on quite soon. We're hoping that this journal helps young dentists accelerate the first few years of their careers, and we're really excited to get this into the hands of as many young grads as we can. As always, if you've been enjoying listening to the Newbie Dentist podcast, please be sure to pass along the podcast to your friends, classmates, and colleagues. If you haven't already, head over to iTunes and give the show a 5-star rating. And if you have some time, please leave a review as well. Without further delay, I hope you enjoy this jam-packed episode with Dr. Mehdi Rahimi and Dr. Mark Johnstone, and enjoy it as much as I did.
Hello and welcome to the Newbie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Newbie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Izami.
Okay, so I'm here with Dr. Mehdi Rahimi and Dr. Mark Johnstone, both endodontists here in Australia, working in Melbourne and Sydney. Super kind with their time and super generous to be here on their Sunday to talk some endodontics with us new grads who are listening. Mark, I had him as a endo postgrad demonstrator during my time at Melbourne Uni, so I've had a chance to work with him and learn from him. And Mehdi, I had heard about you a lot. Obviously, you're involved with teaching a lot across Australia. And I was at one of your courses. You guys held that together a few weeks ago, and that's where we kind of connected and kind of teed this interview up. So I just want to thank you guys for coming on today.
Thank you. Thanks for having us. Cheers.
So normally how I start these things off is a bit of an origin story. For me, one of my big passions is just trying to figure out, high achieving dentists who are kind of doing stuff, even beyond clinical dentistry, running courses and things, sort of what their motivating factors are, what kind of got them into dentistry in the first place. So I guess, Mehdi, we'll start with you since the camera is on you right now. Maybe Give us your origin story, sort of where you came up about why you decided to get into dentistry, and then we'll go from there.
So I'm born and bred in New Zealand. And while growing up, I had two parents that were in the medical industry. My sister actually did medicine as well, but she decided it's not for her. So I grew up in a family of doctors where my parents they were gynecologists, so they wouldn't be home and they'll leave at odd hours to go see patients and, deliver babies. Yeah. I grew up in a extended family with Professor Mehdi Rahimi, author of Principles and Practice of Endodontics, and inventor of MTA, being a distant family member of mine.
Nice.
So I sort of, when I was a child, whenever we went to the States, I would visit him at Loma Linda. And I kind of, grew to like dentistry because I was hands-on somewhat. I liked technology and I liked sciences. So I started biomedical sciences, moved on to dentistry because I sort of watched a lot of dentists work, and I thought, well, it's a good hands-on, probably a better lifestyle because you don't have to work on Saturdays or midnights or early hours of the morning like my parents, and didn't have to worry about that part, and I could sort of select what I want to do. I did, when I started dentistry, I guess have chats with Professor Torbinijad and others, and I always thought I can't be a jack of all trades. I just prefer to do one thing well.
Yeah.
And of course, I did enjoy teaching. I even taught when I was in my undergrad degree, and even when I was doing biomedical science. I just enjoyed that part where I could explain things to people. Anyway, so I asked Mahmoud. Mahmoud said, do orthodontics. Everyone wants to do ortho. It's much better than endo.
Yeah.
And I was like, all right. Well, I did the long course in ortho and it was a bit boring.
Yeah.
Again, I just hope you're not going to show this to too many orthodontists. But orthodontics wasn't my forte. I did the long course at Sydney Uni. I thought, I couldn't handle it. I just couldn't hack it. I couldn't understand it. We never got taught well in undergrad anyway.
Yeah.
So anyway, just to cut a long story short, ended up doing dentistry in the outskirts of Sydney back then. So it is central now, but it used to be outskirts. South Liverpool for gentle dental care. And I was seeing at odd hours because they were giving me weekends and late nights till 10 p.m. I would do a lot of endodontic therapies. I got better at it over time because I still remember coming out, I found endodontics very challenging, accessing teeth. And I still remember this poor guy, 60-something-year-old guy. Someone gave me a tungsten carbide, but I'd never used before. I went right through the furcation, like a size 8 burr. The tooth was unrestorable. So I started from really not liking endo, really, really being frustrated with it, from access to getting down calcified canals on. And then eventually I started to like it because I did more of it. So with practice, I did more. And then I thought, well, I actually start to enjoy this because I focus on one tooth, rubber dam it. It's kind of like, probably to me was a bit simpler than prosthodontics, where you do. But I guess these days, because I've worked with others, I sort of don't just treat the tooth in isolation, but still doing endo is a little simpler because you're just dealing with one tooth most of the time.
Yeah.
That's me anyway. Mark.
So how long did you work as a general dentist before getting back into doing endo?
I did about 3 years.
3 years?
So during the first or second year, with a colleague of mine who's a prosthodontist now, Ben Lee, we lived together. So we did the primaries exams.
Yeah.
It was good to be motivated to do that because he wanted to also do it. So you need someone to do the primaries exams with because it's such a boring and actually ended up being quite a stressful exam because you think to yourself, oh, it's easy, it's basic sciences, but then if you don't, get your act together, 2 or 3 weeks before, you're like, oh my God, there's so much bulk of material. Like I still remember, in particular, oral pathology was tough.
That's tough.
That was the hardest for me.
And at that point, you've been out, you're a few years removed from learning those basic sciences the first time. So it's tough to kind of go back and review everything. And
it was just like sort of rote learning. Ben was very organized. So I never forget Ben's notes. They were so tidy. Yeah. They were just like a Bible, you just go through it, they really helped, to be honest. Whereas I was like, to be honest, all over the show beforehand, and I was working too hard, and I was teaching at Sydney Uni at what's called United Dental Hospital, now it's Sydney Dental Hospital. Okay. So I was doing a bit too much, and I sort of didn't give it enough effort. But I managed to pass. But that was a tough one. But after that, we both applied. So it was the third year out. So we finished 3 years, and then we got in. He got into pros, I got into endo.
Perfect. And Mark, what about yourself? What's the origin story? You can give that to us.
My origin story is a little bit different to Mehdi's because I mean, he comes from a family of doctors and I come from a family of tradies. So dating back like 200 years, the Johnstones are just all tradesmen. So I grew up on and around building sites with my dad, and they always knew I was kind of going to be a weird kid because while they're all, while my brother's busy getting all, into the plaster and what have you, I was always in the corner finding a tap to wash my hands constantly. Mark constantly washing his hands or something like that. But growing up, I was one of those sick kids that was in and out of hospital a lot. And originally I wanted to be a doctor. So I wanted to be a doctor since I was about 8 years old. And, I found a good mentor. My old GP passed away last year, unfortunately. Used to sort of, when I go in there just for my own medical stuff, he'd talk to me about medicine and I'd ask him questions and all of that. And he knew that I wanted to be a doctor. And then year 12, he said to me, it's coming up to crunch time. Pretty soon you're going to be in medicine, and then you can look forward to the internship year when you're doing 60-hour weekends and you're not sleeping, 3 days in a row.
Yeah, sold it.
And I kind of thought to myself, geez, that's a bit rough. I wasn't really having a good time of it in year 12. I kind of thought, gee, I like sleep. I kind of want to have more of it. And dentistry was always on my preference list after medicine because my mum was scared to death of the dentist. We had a really good experience with the dentist. I kind of thought it's always something I could do to help her out. And I went and had a chat to my dentist the week before applications for uni courses happened. And my dentist stayed behind after work for an hour and a half and talked to me about pretty much everything that dentistry has to offer. And he's a general dentist that has upskilled himself so that he does a lot of general dentistry, crown and bridge, endo, but also orthodontics and implant, both.
Nice.
And he showed me what dentistry has to offer, and it's more than just drill and fill and you name it. There's a whole lot more to it. So I thought, this is kind of really cool. So I put dentistry as number one preference all of a sudden, chopping from an 8-year-old to an 18-year-old, going medicine the whole way, then dentistry. Got into dentistry, thankfully. I guess, thankfully I got in. And funnily enough, during the first couple of years at dental school, I kind of chopped and changed as to whether I wanted to transfer into med or stay in dent because first 3 years at dental school, I mean, you were DDS, so it's a bit different for you. But for us, 3 years at dental school was just, first year is science, second year is caries and perio, and third year is caries, perio, and dentures. Honestly, I did not enjoy the first 3 years of dental school at all. I kind of thought to myself, what the hell am I doing here? And I remember one of the guys in the year above me, who's now a prosthodontist, as it turns out, saying to me, just you wait till you get to fourth year, you're going to be doing endo. And endo is the worst thing on earth. You suck, just you wait till you do endo. And no one I spoke to had a good opinion about endo. All of them hated it. I thought, geez, this is going to be like, it's only going to get worse from here. I thought dentures were the worst thing on earth, right? So my girlfriend at the time, who is now my wife, said to me, Mark, your attitude is trash. There's tons of people that would love to be in the situation that you're in. Rather than whinging and bitching about endo is going to suck next year, why don't you suck it up, buy Pathways of the Pulp, and just study it like a beast before you start fourth year, preclinical endo. And if you still hate it after, then fine, dentistry is just not for you. But see if you can change your attitude, and maybe you might start to actually enjoy this dentistry thing. So I did that, and it actually turned out that endo really spoke to me. So I was really pumped up. I'd read Pathways of the Pulp. I was really pumped. Get into my first week of preclinical, get my first tooth, and I break a file.
Yeah.
And John O'More was my demo at the time. John O'More went through postgrad with Mehdi, and someone just laughed at me and said, plenty more where that came from. So I thought, oh, geez, this endo thing might not be for me. But the cases after went really, really well, and I was getting a lot of confidence. And then middle of preclinical endo in fourth year, we used to call it the intensive period. So during 4 weeks, you would learn all the pros and all the endo you're going to do before you start out in the clinics. Second week of intensive period, my appendix burst. And I had some complications after the surgery and spent nearly 2 weeks in hospital.
Wow.
So during that time, there was no iPhone for me back then. I don't think iPhone even released back then. God's showing my age. So I had nothing to do, but the undergraduate endo competition was available. So I got
the essay competition or
competition, yeah. So because I'm doing nothing but sitting in a hospital bed with no internet and nothing to do, I got my wife to do some of the data collection for me. I would have these printouts sitting next to my hospital bed, and I would go through, wrote my essay sitting in a hospital bed in that hospital. And that's what really hammered home my love for endo, because of the fact that I did nothing but endo for 2 weeks with literally just no other distractions whatsoever. And I found that endo really just spoke to me. I don't have an eye for aesthetics. I mean, there's no video going right now, but if you look at me right now, I look like a homeless. I haven't shaved. I don't have an eye for aesthetics whatsoever. And I find that with endo, it's the most biologically driven part of dentistry.
Yeah.
So it's really easy. You come in, you've got a biological problem, and I can help with the biological problem. Someone comes in and goes, I don't like the look of my teeth. I might go, well, what can I really do with that? Like, I think your teeth look fine. Really, my teeth aren't anything to smile at most of the time either. And like, if you look at all the specialties, endo is the one where you have an infection, or you've got an inflammation, or you've got some sort of pain, and you don't need to upsell that either. So I don't need to convince people to do anything in my job, because you kind of need it or you don't. Mm-hmm. Which also speaks to me, because I'm not a salesman. So I did a lot of endo in undergrad. I think I did probably more endo than anyone else in year level at the time, if I remember correctly. I did a lot. I did I think 15 to 16 cases.
Wow, that's a lot, yeah.
That's a lot.
That was just at the dental hospital, not including all the stuff at the community centres, where I tried to take as many endos as possible. When I graduated, I tried to do as much endo as possible, but I tried to do a bunch of everything. So I tried to do a bit more restorative, because I thought, well, you can't just be a one-trick pony. So I did Michael Mendicos and Tony Rotondo did a full mouth rehab course back in 10. I did that, and I thought that was sensational. It also told me that I'm never going to do pros. I was lucky because I worked in a clinic with my wife, and she loved pros, and I loved endo, so I would do the endos, and I got to hand her the pros stuff. I would say to them, look, women got a better eye for aesthetics than me, and patients would go, yeah, I agree with that. And off they go, go to her. I'd be happy. But I just knew that's what I wanted to do. When I had endo patients, I just thought to myself, this is going to be a great afternoon, because I've got an hour and a half to do an endo. Once that rubber dam goes on, it's just me and the tooth, and nothing else matters. So, so that's how I sort of found the love of endo. I did a lot of endo CPD. I mean, I did every endo CPD course known to man, because I was the last year at Melbourne Uni that didn't learn rotary. So I was all hand-fired. So I did every course. I did the GUNS course, I did the Dentsply course, I did the BioRace course, I did the TF course. I learned as much as possible. I went to every ASE lecture. I did a couple of other. I did the Melbourne University 2-day endo course as well, that the contemporary endo they do every year. So I just did all of that and went and observed at specialists as well. So I was very fortunate to have some really, really good specialists that I referred to, who were very kind with their time and allowed me to come down and annoy them once or twice a year to, watch them work. And I found that really hammered home the whole, well, I'm watching what they do every day. I reckon I could kind of like doing this. And so I applied, and I somehow got accepted. And I didn't have my primaries, which is probably the weird part of it. Most people, you have to have your primaries before you.
Yeah, first.
I think it's because I had done so much CPD and I had done so much other endo stuff that sort of, gave me enough oomph to get an interview. But the funny thing is, I'd actually been enrolled for the primaries anyway, because I expected I wasn't going to get an interview. And then I got accepted without them. And because my wife was doing the primaries, misery loved company, and I wasn't allowed to back out.
Yeah, so you still did
I had to do it, whether I liked it or not, even though I'd already been accepted. And then got into endo, and the rest has been just endo since 2012.
So if you're lucky enough to get into the course without primaries, do you still have to do the primaries as a part of your registration, or you don't?
No, not at all. But from what
I think Prof Parashos,
it's an expectation.
As far as he makes it an expectation.
I think it's an expectation now that you've done your primaries or your MRACTIS at the very least. Your resume would have to be pretty beefed up with something else to be able to get an interview, because when I was interviewed, in my opinion, I was the least qualified person out of the 7 people that were interviewed. Like every single one of the other people interviewed had another degree, whether it was one of them had a grad dip in implant therapy, another had a master's of dentistry, another had a master's engineering, of all things.
Wow.
And then there's me. I've been a dentist for 3 years, and I just done as much endo as humanly possible. But in a sense as well, the one thing I had was I had a lot of rounding. So I'm one of those guys that was spending, over 5 figures on CPD a year. I did CPD, I did PROS CPD, I did.
That's the right approach. Yeah.
I wanted to know everything possible in dentistry, even though I was never going to take out an impacted wisdom tooth. I still wanted to know about it, because I just thought the more I know, knowledge is power. So I think that's what got me over the line more than anything else, because I was incredibly well-rounded. And I had pretty good, I had decent marks in uni as well. I won an award, and I was on Dean's Honours list. So I had that going.
That helps, yeah.
That does help significantly.
I think that's one of my limiting factors, is definitely the grade point average during dental school. Yeah, so for endo's cool for me. Coming up, and Mehdi, like you said, you're kind of distantly related to Rabi Najad. That was like pretty cool for me. Like being Persian, I got that textbook. I'm like, man, like one of the top guys in the world doing this is like.
Yeah, the only difference between Mark and I is I found Path as a pulp too long. He likes reading, Mark.
Yeah.
And I had a bias towards principles and practice of endodontics. So that's probably the only textbooks I read more than once during my undergrad years.
Yeah, that's great. So like before we get into the clinical stuff, I guess we'll just talk about a little bit about your advice for new grads, people listening who've been working for maybe a couple of years, who might be considering, is it the right time to specialize, where the trends in dentistry are kind of going. So what's your advice that you would give to someone right now who's thinking about it, be it endo or another specialty, whether it's the right at the moment?
Yeah. So my advice is a mentor is very important. And sometimes I find new grads or just about to graduate, final years, be a little bit picky about where they go in terms of distance from where they live. And my opinion is you go where the mentor is. Yeah. In fact, if you do travel to places like Dubbo or places that might not have, they may not have as many dentists and as many competition, you get to do more and get your hands dirty. So apart from, look, it's, as I said, for me, it was more, I did one thing a lot more and I started to like it. So I'm sure if I was doing another procedure a lot, for example, veneers, which I never liked, I'm the same as Mark. I never had an eye for cosmetics. But even if I was doing that a lot and I did courses, then I did more of it, then I did more courses, I think I would have probably developed a liking towards that. So I think go where the mentor is willing to teach you. They're not, I suppose some of them, you're there and they expect you to bill a lot, or they might expect you to just do the simple stuff like be a orthodontist. Yeah. I think you should go where you can get your hands dirty. And this often with a new graduate means you have to travel to places where, the dentistry is not as competitive. Yeah. And the market in Sydney, for example, a lot of the new grads or final years are asking me. They just got their little profile. This is me. I'm looking for a job type thing. Yeah. They're already all that up ready, and they're about to finish. And I'm like, well, I think you should go out into the country and gain some experience from people that have got more time for you, or older guys that really want to teach you. It doesn't necessarily mean what they teach you is the latest, greatest technology, right? But it just means that you get your hands dirty, you get to see a lot of cases. Then you can do courses, and as Mark said, visit, a local specialist or travel to sit with specialists that are willing to let you go through. So I get 1 to 2 undergrads visiting my practice per week. Sometimes I've got 2 on the same day visiting, and I take them through consultation, the art of consultation, which I learned a lot with Mark, being there, I sort of improved on. I think Mark's the guy when it comes to consults. He's amazing when it comes to writing notes. So I hope he can give us a little bit of his insight on that.
Sure.
But at the end of the day, look, for me, it was more being involved, both hands-on as much as I could, courses. Even I turned up to journal clubs and the university level, and I sort of sat at even programs with orthodontics with Prof. Ali. I went to their seminars. I got up in the morning at 7:30 a.m. and I went there, and I was there late night. I had the privilege to do that because I was at the university level. So I was working with some of the specialists. We didn't have endodontics, so I ended up visiting Loma Linda a lot at the start, and I watched my uncle work, Mahmoud.
Yeah.
He used to work very fast, a different style of endodontics that you wouldn't be able to imagine in Australia.
Yeah.
So he would have 12 patients seen within 3 hours, but a lot of his hygienists and would do the anesthetics to cone fit films, to temporization, to irrigation. Like he would just work like musical chairs. He'd have 6 or 5 people, and he would go from one chair to the other, like around them. So I watched that. That was different. I sat there in general clubs. I watched people access teeth. I even accessed my first tooth in my second year from memory when I was just learning perio. Like second year dance, I sort of was keen to learn a bit more. So during the holidays, I visited different places, and I was in Loma Linda, like accessing a tooth, a lower premolar, I still remember, and a postgrad was suctioning for me. So like at the end of it, look, what I'm saying really in simple terms, if you love something and you do more of it, you're going to love it more, and you'll find your passion. And I still, if I go back, I'll go the same path. I think I'll always do endo. Yep.
Yeah. What about you, Mark? Any advice around that topic for new grads?
So you mean for new grads, or new grads considering going into
specializing? Yeah.
So I mean, Mehdi said it the first time, getting a mentor, but Mehdi focused more on getting a mentor that's a general practitioner, which is great. You need to have a good practitioner mentor, because if you have one, like for example, I normally say it's about extractions. If you have a mentor that doesn't do difficult extractions, then I guarantee you will never do surgical extractions yourself. All it takes another year or two, and then all of a sudden you'll lose the hand skills, you'll lose the confidence, and you're never going to do it again. So you need to have a mentor that's willing to let you actually do whatever it is that you're interested in. But having said that, you also need to start small. I know a lot of new graduates seem to think that once you've graduated, my certificate allows me to do everything, so I'm going to do everything. Like I'm going to take out an impacted lower 8 very first time I get a chance. I'm going to do a molar endo very first endo I get. And it just doesn't work that way. To get good at it, you've got to build up to it. So I normally say that tackle the easier stuff first, so you build up confidence, not just in yourself, but also in the muscle memory from the clinic you're working in, because every clinic's a little bit different, different setup, everything else. You're also building the confidence that your boss will have in you and thinking that you're not hopeless. Because if you take hard cases at the start and you screw them up, they're going to start thinking you're hopeless. If you do a bunch of really straightforward cases and smash them home, they're going to be thinking, well, okay, it was a bit hard, a bit more than you could bite off, but you know what, you'll get there. So my advice, if you're starting out, is whatever the cases that you are interested in, pros, endo, perio, if you really like perio, I guess, keep a logbook, right? Have your own personal
That's a great tip
of those cases, so that you can see your own progression over time, and you can actually objectively see where can you improve and where can you not improve. And rather than focusing on time, because a lot of new graduates, I think, focus on time, where they're like, oh, it's taking me 2 hours to do this and my boss does it in half an hour, whatever. The time, it comes. Speed comes with experience and practice, and that just takes time. You can't rush it. Focus on things more like for your endos. Am I getting to length? How accurate are my films? How accurate is my restorative? How's the obturation look? Am I breaking instruments? Am I not breaking instruments? How do they go from an outcome point of view? How hard were they to isolate? All that sort. You keep a track of all of that, and you try and see the areas that you feel that you could improve faster, or you think you're going well, or areas where you need to ask someone that knows this stuff questions. And that is actually the best way that you can learn, is by keeping your own little personal logbook. And then when you see the progression, you can be like, okay, I think I can now tackle some harder stuff because I've been able to do X, Y, Z. It's also good if your boss ever says, what made you think you could do that? And you're like, well, I've got this.
You've got the logbook behind
I got a little logbook that I keep for my own purposes of how much but the other part as well is having a mentor in the specialist realm is also very important too. Because I've got quite a few dentists now, but used to be students who during my postgrad days, they had an interest in endo. They'd ask me questions. They shoot me messages on Facebook, SMS. I get probably 3 or 4 messages a day from people asking me endo questions just in general. They can be anything from here's a film, what's going on, to just a really esoteric question about endodontics in general. And having that sort of mentorship relationship can really help you improve as a general dentist, but also improve your love for a specialty. And sometimes the advice will be, look, that's above your pay grade. You've got to refer that. And there's not trying to fish for referrals. It's just a matter of that's the appropriate option. But sometimes my view is I've had a lot of situations where a dentist has messaged or called me, and 5 minutes of my time can save them a good week or 2 of stress and a whole lot of sleepless nights, and sometimes all it takes is speaking to an expert and saying, this has happened, oh my God, what do I do? And someone like me or Mehdi or whatever specialist you're using saying, it's fine. It's not the end of the world. These things happen. Just this is what you do and it'll get managed. And I think that's really, really helpful from a personal and a professional development point of view, because what a lot of people forget is the fact that dentistry is a very thankless job.
For sure.
You can have 9 cases in a row that go well, but you have one patient with an MO with post-op sensitivity, and the patient thinks that you're the worst person on earth, and they're on the phone every day abusing you and saying you're a piece of garbage, and they want their money back, and they're going to sue you. It just takes one patient to ruin your entire day and make you think, why are you doing this job? So you need to all have that, not just professional support, but also that emotional and personal support to remind you that it's not the end of the world when these sorts of things happen, because we all get them. Every single specialist, every single guru, every single expert has those cases that make us want to lose sleep and just leave the profession altogether. So you need to get some personal and professional support. The other thing as well, if you want to do a specialty, in my opinion, is save.
Financially tricky.
Save. You've got to, you can still have your smashed avocado here and there, but you've really got to make sure that you save a lot of money, because you're going to earn nothing in postgrad or next to nothing in postgrad. And anything you do earn is going to get chewed up by what you're doing in postgrad anyway. So save money, because you're going to need it, and you're going to chew into your savings during your postgraduate days. It's just a fact of life. You can't get away from it. And then when you're in postgrad, make connections with people, make connections from other specialties, try and learn from other specialties as well, because it will help you. With endo, we do a lot of stuff with perio and pros, and that gives you a lot of perspective of what's out there. But just also take the time to teach. You really don't know things until you have to teach it, or with us with our lecturing, until you stand up in front of an audience and you start talking about something and someone asks you a question, well, you don't really know it until you actually explain it in front of a group of people and not sound like you're fishing.
That's great tips. I think the few big pointers there is definitely mentorship. And I've been doing this podcast, I've been talking to a lot of dentists who are doing a lot of great things, and that's like a universal one that you hear all the time, is you need that good mentor from the start to kind of guide you and show you the way. The tip of starting slow and kind of building up is one that I wish I kind of learned a bit earlier. And you hear a lot of people say, make sure your first couple of cases are slam dunks to kind of get your confidence up and get your skills up. And for me, like personally, I know a lot of other people are the same boat. You come out of school, you think you're on top of the world, and you think you're very, very confident. It's like that Dunning-Kruger effect of you don't know what you don't know, and then you get stuck, and your first endo you're short, or you don't get to lengthen, you're not happy with it, or your first crown or your first extraction takes longer. So those are all great points that you said, to really take your time, build it up slowly, make sure you got the right mentors in place to kind of guide you through those progressions. Having those relationships with the specialists as well.
I'll probably add one more
Sure.
thing. I think gone are the days where a specialist communicates by referral letters. Some specialists still do that. Maybe the older specialists. Nowadays, you've got, where we're communicating right now, obviously by iPhone. I think for me, I spend a lot of time discussing cases, and I even give my phone number to dentists if they wish to have it when it comes to trauma. Because with trauma, for example, I just had one guy message me over the weekend because they saw a really bad trauma on Saturday, really, really heavy trauma, avulse teeth and root fractures and, extrusive injuries and everything in one. So they messaged me and they called me straight as soon as the patient's there. I managed to get on the phone and just explain how I would manage it. I saw the radiographs, I was on iPhone, they just gave me a little look at it. Diagnosis, trauma, multidisciplinary cases really mean that there is Facebook private messaging on Facebook, and there is gone are days of referral letters and, can you please let me know what you think? I think phone calls and a little chat and regular discussion meetings with your local specialists. We do, for example, I know Ben Lee, he has his study club, and he meets up with his own private, just very top referring dentists on a monthly basis. So this is the future. The future is communication, and never treat the tooth or the situation in isolation. Know that we're here to help you guys. And as Mark said correctly, just a 5-minute chat changes, the outcome. And for us, it's about the patient at the end. It's about you guys communicating with us. So this is, I think, very important, communication. And as you go even through postgrad, I've got people sending me radiographs and going, I had this case, or what do you think about that? They've got other opinions from their mentors, but they may want to have another opinion from somebody who's a clinician in some situations.
Well, no, that's great. That's great advice because, even with Facebook and Instagram and social media, it's much easier for dentists and specialists to kind of connect and kind of share those things with each other. I was talking to a prostodontist a few weeks ago, and I was telling him that referral system seems very archaic of writing a letter, attaching your radiograph, sending it off. You're not sure where they're at with the process. So making that communication, like you said, easier and having more feedback more quickly and back and forth, I think it makes a big difference in the patient care as well.
Well, there's something I'll add to that as well. And this is more of a personal thing more than a professional thing. But if you plan on postgrad, get married before you enter postgrad.
Make sure they're committed.
No, because once you get into postgrad, you meet so many more people, your guest list is going to spiral out. Just
okay. So that's another way postgrads lose money, huh? The wedding costs go up.
The dates during postgrad are expensive, I could only afford soup, while they would order the barramundi at $40 a dish.
So tell me a little bit about, modern day endo. Obviously, a lot of us new guys, we come through dental school and we get the basic introduction to rotary and stuff. There's so much going on with cone beam and new rotary technologies and diagnostics. Obviously, we don't have to get too in depth, but if you just kind of give us some cool things that are emerging that you're seeing in your field that are kind of cutting edge, just for a general dentist to kind of be aware of that they even exist, that'd be cool.
Yeah, so that's me.
Yeah, Mehdi, you started.
You can both have
okay. Yeah. Mark will cover whatever I miss. Look, I think keep things in balance. So whatever you learned in at school, slowly develop and learn. Don't just because the cone beam is out there, do cone beam and not do periodical radiographs or check your restorative margins with biowings, because that's a definite no-no. You come out and you go, oh, this is good technology, but then you haven't been taught how to use it. So being taught how to use a cone beam, read a cone beam well, what type of cone beam to take is important. But certainly, if you do have cone beam technology, I see a lot more in many situations, but I don't overdo it either. I don't start to cone beam everybody, every single case that walks through, young and old. You got to keep the relative dosage right, with kids especially, less, they've got the relative doses obviously important, and I think we're overdoing it sometimes with technology.
Yeah.
So keep it in balance. Ask the specialist when they use a cone beam and for what situations, and then go from there and do courses whereby you can actually learn how to use or read a cone beam properly. That's my first advice. So definitely cone beam technology is good because it tells you more about strange anatomy. If you're struggling with a tooth, you can at least take cone beam, see where you are and find a calcified canal. In some trauma cases, very useful in finding out exactly what type of trauma you have. You might miss stuff with two-dimensional for sure. Okay, so that's one thing. Second thing, I think with the world, in my opinion, of agitation of the ear again, there are all these new devices coming out to make your life easier. So it's not about the old-fashioned, okay, I've got to go to, this size and this shape. I think nowadays you probably can be a little bit more conservative in certain circumstances and see how it goes. Like, I'm always a fan of, to be honest, medicating and waiting. I think it's better patient management. I also can see signs of healing. Yeah. And so sometimes these days, it's not like when I first came out. So when I first came out of Melbourne, I probably would go every single palatal canal to a size 60. Like it was just a standard 60-04. I got taught 60-04. So I kept the flare pretty small. That was good. It minimizes risk of fracture. We know that. Some of the old step back techniques, the Gates Glidden days, sizes 4, you just really have a 10 or 12 flare. So you keep your flare up the top small and you go to large apical sizes. But then over time, I think what's changed in my practice is I've now gone to in calcified canals in some shapes. For example, the MB2 canal that's always calcified. When you look at the root and cross section, it looks quite narrow. I'm actually going to a 25. I might even use a very, very, very fine taper and keep it to a minimum, the taper. And I think it's because I'm able to agitate the ear again better, and I'm using better agitation technology. And there's future, the future, if we can afford it, the $80,000, gentle wave might become more affordable, whereby you can have tinier holes in teeth and you're able to disinfect. So I think the world of disinfection, the world of agitation of the ear again is the big world right now in endodontics. We're moving away as much from calcium hydroxide or antibacterial medicaments, although I still use them as a space filler and I still, try to get them in the right spot using Navi tips. Navi tip technology is pretty cool. Okay. From Ultradent. I think that we can get tinier, finer needles and we can get them deeper, and we're able to get their medication into where it's necessary. So that's, I think, for me, the big changes, plus one other change is saving pulps. I think pulp is resilient and we can, in many cases, not extirpate it. We work with the pulp we have and we use bioceramics and MTA type materials to preserve the pulp properly and let that root grow in a young patient, for example, and let that thickness happen. So I think that's another area, with, cells and stem cells and, the future with preserving pulps and revascularizing teeth and teeth that are even infected. We can give them a better chance at regrowing, if you like, or, getting them to thicken and strengthen. That's my part.
Okay, Mark, anything to add?
So I'll add a couple of things on the medis first. So first, the revitalization, vital pulp therapy stuff with MTA, some of the new bioceramic coming onto the market, I think is absolutely sensational. I think that sphere is only going to improve as the years go on with better materials. I don't imagine we'll ever get to the point that we have personalized dentistry like they got personalized medicine, where it's like this medicament is special to your pulpiome, let's call it. But I do think that space is really worth watching, because Mehdi and I have had a lot of cases of, we're talking 6, 7, 8-year-olds where they've had just bored out with caries, but you don't want to extract it because they're young. And you just do a full pulpotomy on them as a temporary measure. And the roots continue to grow and the tooth sort of stays there. And the aim is just to lock it into their head till they're 25, really. It's a temporary, but it's better than the alternative. I know if it was my kid, I'd give that a crack. So I think it's great. The other thing as well, when you talk about CBCT, this is probably another advice for new graduates. So there's lots of people that are doing in-house CBCTs, and they're great in-house CBCTs, so it's against a technological advance. The problem is, and this is something a lot of new grads are don't quite realize, you take the scan, you are legally obligated to report on that scan and to note anything abnormal on the scan. So if you don't know the normal anatomy of the sinus cavity, or if you've done a full head CT that's got part of the ear involved or the cervical spine and you miss there, you are liable. You are liable for anything you miss there. It's no different to, I remember back in one of my very first weeks of undergrad with Pam Craig, who I don't think at the University of Melbourne anymore, saying when you look at a scan, she had an OPG, she's like, look everywhere but where you're meant to look first. And with a CBCT, there's just so much more you need to look at. So if you don't have the actual training to look at it, you're going to be fine probably 9 out of 10 times. But that 10th time, you're screwed. And it's going to happen. There will be some sort of litigation that will happen at some point in the future that will set the standard that, we probably should have been doing this a lot better the whole time, but get ahead of that curve, because patients are complaining more, patients are more aware of their rights, which brings me into what I think that is sort of the emerging technologies is the internet. Patients today have access to so much more information than they had in the past. Not just good information, but things like root cause, the Netflix topic. For a while there, I think every endodontist in the country was having 1 or 2 patients a week, giving them headaches, wanting to tell us that we're cancer-causing monsters that are just in it for money. And
I'm still getting that, Mark, by the way. I'm still honestly.
And being aware of the fact that dentistry, like all aspects of medicine and life, there's certain things that are out there on the internet that are gaining traction, that people want to believe, and they're going to ask you questions about it, or they're going to hassle you about it. And some of them get really, really aggressive, and you need to have it figured out already what you're going to do when a patient comes in like that. And everyone reacts differently. I used to try and have a reasoned conversation with them about what the evidence is, and and how the fact that there's no actual evidence for what they're talking about. But that doesn't tend to end well. So now I just tell people that there is no evidence, but you're welcome to believe what you believe. And if you really do think that what I'm doing causes cancer, then by all means make a complaint to the dental board, or tell your holistic dentist to make a complaint to the dental board. And they don't, because their holistic dentist knows that it actually isn't the way it is. So being aware that you are going to come across certain personalities that are going to have this in the back of their mind, but also knowing that you need to know what you're talking about, because there'll be a lot more patients that actually know about endo and pros and perio and maxvac and everything else. So gone are the days where the patient walks in, they sit down, you say, open up, I'm doing a root canal treatment, and they do it. You spend time talking to the patient and giving them the respect they deserve so that they can make an autonomous decision. So that's sort of a side thing. The one thing that I've noticed, which I think is great, is the improvement in, the affordability of dental operating microscopes. There's a lot more GPs now that are using the operating.
That's a good one, yeah. And
I know some GPs that are using it, and they've said that they've noticed a vast difference in the outcomes and qualities of their treatments, even doing things like crown preps under a microscope, which I can't imagine ever doing.
Yeah.
But now microscopes aren't, they don't cost the same as a small house anymore. You can actually get microscopes for some pretty decent prices, and I think it just improves your treatment outcomes. And I think that's where the tide is turning for people that want to do more complex treatment. They're going to be using scopes, even if it's under low magnification on a microscope. Will make a significant difference. So that's sort of where I see the tide going from a practical point of view with endo. You mentioned from a diagnostic point of view, diagnostics sort of hasn't changed all that much, in my opinion. I mean, it's really still back to the basics. Don't cut corners, still listen to the patient, still do all your proper tests, don't try and skip ahead. The only thing really I say is that cracks find new and imaginative ways to make our lives difficult. They're always a pain to diagnose properly. But I've been seeing a lot more, even in the last 5 years as a specialist, a lot more patients with referred pain from temporomandibular disorder.
Okay.
I don't know what it is, but there's a lot more people out there with jaw joint problems, muscular problems that are referring to the mouth. So I don't know whether it's a societal thing or whether I just be having a real bad one of it. But yeah, just knowing your oral med stuff, it's probably a good idea to at least know when not to pick up the drill.
And now a short ad break from our sponsors. Are you looking for a hands-on course to complement your current CPD plan? Henry Schein offers 150 CPD courses every year in all topics, including endodontics, orthodontics, surgery, infection control, and practice marketing. To view the current offerings, head over to henryschein.com.au to check out all the CPD courses available for the upcoming months. And as a special offer for my listeners, they are offering a 5% discount on all courses run by Henry Schein using the promo code PODCAST. Again, that's promo code PODCAST for a 5% discount on all CPD courses run by Henry Schein Australia. Head over there, check out their courses, and I hope to see you guys there. Yeah. So I'm just going to ask one kind of like philosophical question, and then we'll, being mindful of your time as well, we'll get into a quick clinical kind of scenario, and then we can chat about your courses and stuff, because I really want to get to that as well, because I know you guys offer a lot of great courses that are really useful for a lot of new grads, so we'll give you the kind of the platform to talk about that. But in terms of the philosophical question, I came to your course a little bit, and you had that great segment on, the consent process, and not to say that it invokes fear for like new grads and stuff, but as a new grad working out there, this fear of like litigation like hanging over your head, personally, and I have friends that are in the same boat. We talk about this, is it kind of weighs heavily on us in terms of our job satisfaction, in terms of like burnout and overall stress. How can we, one, be mindful of it and try and cover ourselves and protect ourselves, but also like not work day to day from like a place of fear of like anything I touch and do is like a potential lawsuit. Like, I think that's not a healthy mind space to kind of be in. So like, what's your advice around that?
I'll take this one first, Mehdi.
No, go for it. Yes.
So first off, the disclaimer, not a lawyer. I don't work in the complaints and claims handling processes. So everything that I say is just based on my experience as an endodontist and working with patients and dentists and all of that. I just finished a Masters of Health and Medical Law at the University of Melbourne, so I've got some extra little legal qualification, but I am not a legal practitioner, so bear that in mind with what I talk about. So first off, I think practicing defensively as a dentist is a recipe for disaster for yourself, because you're going to be doing nothing but scale and cleans, and you won't do any of the hard scale and cleans, you just do the basic one. You'll be scared to pick up a drill and do anything. So at the end of the day, the majority of what you're doing is probably fine from a technical point of view. It comes down to treatment planning, and it comes down to communication. So when I sit down with a patient and do a consult with them, I spend a lot of time talking to them, because it's not just me trying to figure out what their problem is. They're trying to decide whether they're willing to let me treat them, but I'm also determining whether I should be treating this patient as well, and whether I can live up to what their expectations are, whether they're reasonable or unreasonable. Can I actually live up to them? And can I actually do what I think is the best job for this patient? So if you don't spend enough time with a patient actually chatting to them, you're not going to pick up on all those signs that you shouldn't touch the case, which is why I say new grads, you start easy, you start small, and you build yourself up for that confidence level so you know how to deal with it, because complications happen. If you have a complication in a relatively straightforward case, they are relatively straightforward to deal with. If you do a harder case and you have a complication, first off, you're not experienced enough to know how to deal with all those complications. But secondly, complicated cases get complicated complications.
Yeah.
You can't say that 3 times fast. So it's mostly just spending a lot of time actually talking to your patients and communicating with them, because first off, from a consent point of view, you're doing the right thing. You're protecting yourself, because you are actually taking the time to run the patient through everything that's relevant to them in this case. You're letting them make a choice. You never make the choice for the patient. If they say, what should I do? You say, well, I can't tell you. That's not my place to tell you. If they say to you, what would you do? Remind them the fact that you are biased. You financially benefit if they proceed with treatment, so you are the wrong person to ask. I tell people that I'm a root canal hammer and your tooth is a lucrative nail.
Yeah.
So you can't make the decision for them. You give them all the information. And honestly, the best thing that a patient can do is say, let me think about it. They go home and they come back another day. So don't be so quick to get someone to do treatment immediately on the day. And let's imagine you did do something and a complication does happen. Most of the time, complaints are made due to a breakdown in communication, whether that is in the informed consent process or after a complication has happened. So typically what I see when we see endo patients, and some of them are angry, and they're typically angry because something's gone wrong in that communication pathway where I wasn't warned that an instrument could break. Well, they can, and they do, unfortunately. It's just part of life. It's not negligent, it's just part of life, which is why you warn them beforehand. Your indemnity will thank you for warning them before. Or they're upset because of the financial part of it or some other aspect to it. So if a patient has post-operative pain, you don't fob them off. You offer to bring them in and see them for 5 minutes just in between patients or at lunchtime, or you offer to, if it is a swelling or what have you, you send them a script. You don't fob a patient off with their concerns. You keep the lines of communication open. If something goes wrong, be quick to apologize. And I found from experience, be quick to hand some money back. So what I will see is patients will come in with a broken instrument, and the patient will say to me, I've already paid X amount of $100 up till now, and I've got a broken instrument, and now I've got to pay you all this money. I don't think that's fair. And I mean, I can't really comment on that because relative. I mean, I'm external here. I'm the guy that's meant to be helping you out with your tooth. When I was a general dentist, the recommendation that was made to me by the endodontist I used to refer to was, in a situation like that, reimburse the patient for every cent they've paid for your root canal treatment. Yes, technically you shouldn't have to because it's a procedural fee, blah, blah, blah. But honestly, goodwill costs a lot more than sleepless nights. Yeah. Give them their money back and offer to do them a deal on their crown. So typically what I used to do is I'd say, right, the cost difference between our root canal treatment and the endodontist is $800. Your crown is $1,500. What I'll do when you come back to me for the crown, I'll do your crown for $700. And that way you are not more out of pocket than you would have been if you had gone to the endodontist on day dot.
Yeah.
And
that's a good point.
That tends to keep people really happy because most of them can sort of figure out, hey, that makes sense to me, and it also makes the patient feel like you're looking after them. What you don't want to do is you break an instrument, the sweat starts running and you start freaking out and telling the patient that I'm going to look after you forever and I'm going to give you your money back, I'm going to pay for your endo and I'm going to pay for your crown, I'm going to pay for your implant, and I'm going to pay for your kids' education.
Yeah.
You've got to temper it a little bit and figure out in advance how you're going to deal with those complications. And honestly, you do that and most of your complaints will go away. The complaints that are going to cause you headaches where you end up in front of AHPRA or with some sort of severe litigation is if you do something beyond the realms of what a professional should be doing. Or if you have some serious complication from a serious procedure, like you have an endo and the endo fails and the patient's angry to complain, realistically, what's the worst they can get from you if you've done good quality work to the standard of care within your realm of capabilities? Really, the most they can get is money back for the endo that you've done, maybe the implant if something went wrong. Full disclosure is a really good thing because the hard part I find with new graduates and dentists in general is they don't like telling patients that something went wrong. Yeah. So what I've learned from experience, and I learned this from a Max Fac, is you always start the conversation positive. You always say, thanks for sitting through that. Look, the procedure went really well, except in one of your roots, one of the instruments has broken off. Look, it's not the end of the world. It's not going to cause you any pain. It's just something that's happened. I'm going to get you sent off to a real good specialist that can get it managed. And as a gesture of goodwill, I'm not going to charge you for what we've done up till now. And after you've seen the specialist, XYZ, whatever, like you'll have your spiel for whatever the case may be. Yeah. And you always start with the positive. It went really well, but when I was trying to find one of your little root canals in there, made a little pinpoint communication between the root and the bone, which isn't the end of the world. I'm going to send you off to someone that can fix that up, no problem. Yeah. What you don't say is that I went through the side of your tooth in the wrong direction and now it's... Yeah. So communication, honestly, is the big thing.
That's a great tip.
You don't tend to learn this in dental school. You tend to learn it from your mentors, and you can get some really bad learning. from it. So just be mindful that being open with your patient, disclosing something that's gone wrong. You're not admitting fault per se. You're not saying, well, I've said sorry and I said this happened, therefore they'll sue me. It'll look a hell of a lot worse when they see someone like me and I have to tell them there's a broken instrument in there. And I've had that happen. I've had with perfs, I've had with broken instruments. I've had, we have patients that get referred sometimes and the dentist is like, don't tell them the file is in there. And it's like, well, hell, I've got to. So, yeah, that's my thing. Mehdi?
Yeah, look, just to add to that really is time at the start is important. Even if you don't have time at the start, create time at the next visit to discuss the procedure that you may be thinking of or you've started, for example, endodontic therapy. Give the patient some information because the ADA has all these pamphlets, so they can even walk away with it and go and read it if you don't have time and it's an emergency. Yeah. So when they come back the next visit, you can spend time. You don't hurry at the start, and you can discuss all the procedure, all the possible complications. Because although we don't worry about a separated instrument, right, and we often can manage it, it's still important you tell them about that small risk of whatever it is, 3%. It's still important when they leave your practice, you tell them about the 3% risk of flare-up. The post-op calls I found where my staff do are important because it just means better patient management and care. Yeah. So I think one thing is time. Don't hurry at the start. I learned this from prosthodontists like Ben, who spend 90 minutes for a consult, and it's still not enough, and they get the patient back for another 90 minutes. So sometimes there are patient factors, and you're trying to explain something to them, and it's throughout the process of time, really. And this is something Mark knows quite well, and I've sort of listened to Mark about this. You find out the patient's personality. So I'm not saying that now I still don't get it wrong and I don't dig myself a hole, but you find out what type of patient you're dealing with. Whether old or young, patients are different. Some are more type A, some have high expectations. Some obviously are very okay patients. They're the patients that understand and are less likely to get upset if something fails or goes wrong throughout the process. So be aware of the red flags at the start. The more time you give yourself to get to know this patient at the start, but develop some personal, I think, personal relationship really means you write in your notes that this patient, I don't know, told me that they watched the rugby and they watched, the All Blacks lose or win. Then you go, okay, well, they like the All Blacks or not. You get, Mark's all about basketball, so he loves he's looking forward to probably the Australian and the US matchup, right, Mark, in Melbourne. So the reality is everybody's different, okay? And that also brings me on to another point. In line with, I think the word that I use sometimes, which is under-promise and over-deliver, is something called endodontics. And I really wanted to touch on this endodontic aspect. I know that Professor Troy Benijad on the 21st Saturday morning in Sydney will cover this part, which is the patient factors and why we do sometimes endodontic surgery or root resections or even auto-transplantations that are, say, a dying field or they're not there anymore because everybody does implants. Well, what we're seeing really is that we can get, failures even with implants over time, and the literature is changing. The pendulum is swinging the way of saving teeth again. So we can save teeth, we can be more conservative at saving them, and we can even push the boundaries and do endodontics. There's nothing wrong with doing endodontics as long as the patient is on board. Yeah, I always tell the patient, and I select my patients, and I always make the example of this plastic surgeon who has a 40-50% success rate because the other 50% of patients die. At the end of the day, it's a tooth. We're talking about a tooth here. The worst case is extracted. So don't be, I always tell, I've added this to my consult, Mark. You'd be glad to know. I don't know if you agree or not. And I'll let you, you're the consult man. You're the guy who communicates much better than anybody else I know. In terms of I watch my peers, older and younger. And I think Mark's really good at his note writing. We read his notes and we're like, wow, He hasn't missed a thing. He hasn't missed a thing. Every single time he hasn't missed a thing. So he's just top notch. But what I'd say is right at the end of my conversation with the patient that I've selected to do some compromised tooth, decided to try to save it. Of course, I'm going to assess it well. I'm going to follow stripping everything out and Paul Abbott's way of assess the tooth properly, remove everything and have a look at it before you decide again on whether it's worth saving or not. But I'd say this to the patient, don't be upset when this fails.
That's a great line.
I've already told you this now, that we're going down a path that's somewhat more unpredictable. I'll do everything I can to the best of my ability with the rest of the profession, say the restorative dentist or the prosthetic, to save this tooth. But at the end of the day, when it fails, don't be upset, because we've told you from the start that we're going down a path of more, that could be more challenging, that could be a bit more unpredictable than an average case. But I think I save teeth these days, and I push boundaries sometimes. And I know Mark, sometimes we run through cases like, Mehdi, what are you doing? I love healing. I love the human body and what it shows me sometimes. And I selected an old patient, especially the 80-year-olds, the 75-year-olds, where the life expectancy might be different. Some periodontics sometimes. I do save the compromised tooth, and I love seeing it work in some patients, and I love keeping their teeth, because also an old patient, when they lose a tooth, they may not have the means and they may not wish to replace it with an expensive option. And they might not want to wear dentures. It might be not socially, even at that age group's acceptable, it might be depressing for them. So I push boundaries. I save teeth. I've also seen the literature, and I just want to come out and say one final thing. The literature tells us that implants are great, but between 6 to 10 years, 46% of them need maintenance. This is the best available, the systematic reviews. And the success rate in some areas is higher than others. And in the upper sinus region, the upper 7, we argue till the cows come home. We have, multiple specialists in one room saying, let's save the upper 7 or 6. That area, the success rate's lower. It's in the 70s, high 70s, low 80s. It's not like that. Like people think you place the implant, it's going to last forever. So you just go with the patient. You understand the patient. And if I'd rather send the patient away, say, there's the door, go to the older endodontist or go to a specialist and have an implant if I find the red flags. And I want Mark just to maybe add to the red flags part, because I think you're very good at explaining.
Give us some red flags that you've picked up from your time. That'd be awesome, Mark.
So pretty much, well, the first off is if the patient's got a history of suing or making complaints against their previous practitioner, it's probably a good idea that you don't see them. Look, past behavior is the biggest predictor of future behavior.
Yeah.
So they might have had a legitimate reason for complaining against their previous practitioner. But if you're going to be doing something complex, especially, it's probably best you send it off to somebody else to do it, unless you are super confident in your ability and you're willing to deal with the complications that are involved. They say other red flags I've had with patients is over-argumentative patients. If I say to a patient that, look, for your root canal treatment, I'm going to have to do this in multiple visits for whatever reason. At the end, I'm going to put in a base, I'm going to put in a core, and I'm going to send you off to your general dentist for a crown. And if they say no, you're going to do it in a single visit, and you're going to do the crown. And I'm like, no. And if they keep arguing with you every step of the way when you're explaining how you have to do it, that's when you need to take a step back and say to the patient, and this is what I say to patients, and I do. I've got a very low threshold's the wrong term, but if I know that things are not going to go well with the patient, I stop it early before I've picked up a drill, if I can.
Yeah. I
just say the reality of what I can do and your expectations, they don't mesh, unfortunately. And in those situations, I said, as a gesture of goodwill, I won't even charge you for today's consultation. Mm-hmm. So you've lost nothing but time for coming to see me. So I'm happy to give you the details of another endodontist or endodontists that you can inquire with, or you can go back to your dentist and ask them for the details of another specialist. And I found that does mitigate a lot of problems. Another good rule of thumb is if you're dealing with a patient and you think to yourself, if something went wrong, I don't think I would be happy. I don't think I'd be capable of having a conversation with this patient about it. That's another red flag, because you can't guarantee what's going to happen. My advice is treat every single patient as if they're a personal injury lawyer specializing in dental malpractice claims. And if you look at this particular patient and think, if they were a malpractice lawyer, I wouldn't want to touch them, then you definitely probably shouldn't. I have worked on a dental malpractice lawyer in the past, actually.
Yeah. That would have been fun.
I work on that patient who's a very understanding human being. But I've had other patients where just, you know when you're talking to them, I've had a few, and because of the fact that when I've shaved, I look like I'm 15. And I had this one woman that Mehdi has saw recently, and the whole time during the consultation, she'd interrupt me at every second sentence and say, "You do know what you're doing, don't you? You are a specialist, yes. You have been a dentist for a number of years, yes. You do know what you're doing, don't you? You've done this before."
Yeah.
About halfway through the chat, I just stopped and I said, "Look, I get it. I'm young. Young is relative, but I'm young. And it's obvious to me that you are uncomfortable with it. I don't take offense, because there's no point taking offense to it, by the way. Everybody's opinion is their opinion, right? Yeah. I don't take offense to it. I'll get you seen by the most experienced person at our clinic. And I'm not going to charge you for today for coming to see me and having this little chat. But in my, and this patient was like, no, we can continue. And I said, look, if something went wrong, would you believe that something went wrong because it was going to go wrong? Or would in the back of your mind, it would gnaw at you that it went wrong because I'm inexperienced? And she's like, okay, fair enough.
Yeah.
So sent her off to Mehdi, and she was perfectly happy with Mehdi. I think it's the grey hairs.
Yeah.
Happy with Mehdi. So that's another red flag. When you're doing the consult with somebody, and if they're not paying attention to you, or if they seem like they're you know when you're talking to somebody and they're just almost mocking you with their reactions rather than actually being engaged and listening. I've had somebody be on their phone while I'm talking to them about their consult. It's like, you're right there. And they're like, oh, yeah, but how much longer is this going to take? I'm like, well, this is an important conversation that we're having here. If you're rush or a rush, you can leave and come back another day, but I'm still going to have this conversation with you.
Yeah.
Because you need to understand this. And if you're not going to, if you don't think that I'm the guy for the job, or if you want to see someone that's not going to talk to you at all, then I'm not your guy.
Yeah.
You know, so it's just those are some of the red flags. A little red flag that I've got that it's not always perfect. Big indication. So when I talk about broken instruments to patients, I say to every single patient, doesn't matter if it's a straightforward incisor or a curvy molar, I say, look, there's a possibility that one of the instruments can break, and it's not the end of the world. They're not going to set off metal detectors at the airport. And if the patient cracks a smile or laughs, I'm like, okay.
It'll be fine.
But if they're stone-faced when I say that, that tends to be an indication that I need to be a bit more wary of the personality that I'm communicating with. It's not always perfect, because some people are so nervous in the dental chair they just don't react. But that tends to be a sign.
Yeah. Later. No, that's really useful. A lot of practical tips in there. I think it's important to get these, it's like that sixth sense that you kind of develop over time as you're working a lot. You get to pick up something's off about this person. I'm not sure if it's the right thing to actually start treatment. And even so, like as a new grad, there's even cases of, you start a case and like immediately like, oh man, I shouldn't have started. Yeah. Like in your mind, you like right away, like that was a bad decision, and you're committed now. You're stuck, so you're into it.
Well, actually, no. What I'll mention for that, say that you're committed, you can always back out. Doesn't matter what procedure you're doing, you can always back out. So, Mehdi knows this. I paid my way through dental school playing poker, right?
Yeah.
And there's something called sunk cost fallacy.
Yeah.
You've bet so much money into the pot that you're going to keep chasing and chasing, even though you know you're going to lose, but because you've gone so far.
Yeah.
Back out, fold your cards. If you're in the middle of a procedure and you're thinking, I shouldn't have started this, stop. If it's an endo's great. Medicate cavet. Cavet is the world's best invention. Medicate cavet. I'm sorry, we can't continue. This is beyond my. And you say to them, I thought that this was within my capabilities to treat based on my assessment and my 2D examination of your films. Unfortunately, going in there, it's not. It's harder than I expected. You need to see my colleague, a specialist, whatever, and it'll be so much better for you than if you keep going. Same goes for crowns, same goes for surgeries, ortho, what have you. As soon as you realize you're going too far, pull out early, because it's a lot easier to tell a patient now than it is when something else has happened.
Yeah. I think, one line I use is, before I do anything irreversible to like damage anything, let me stop now and I'll send you off to someone. Yeah, and I think they appreciate that.
Exactly. Just always pull out early when you can. And like, I've had cases of mine where, I mean, I'm an endodontist, but I am a junior endodontist. I'm not 15, but I am a junior endodontist. And I've had cases where I've started it and I've gone, this is beyond me. And I get it sent off to someone like Mehdi, who's got, a decade's experience on top of mine. And, I think, Mehdi, you've had one or two where you've said this is beyond you as well, if I'm
and because sometimes you just simply don't know until you start. So you start and you're like, whoa, this is more complex. Mm-hmm. It's either anatomical, it's either the unknown. And I also add this to it, that sometimes you see healing, Healing is important because you do a review and you think, Mark, you've done your Academy Award-winning endodontic therapy on this tooth, and then you're like, the tooth next door's got a hockey stick style, Ninja Axis style endo, and you're like, whoa, that one actually worked for many years. It's got silver points or whatever, and yours is perfect. It just doesn't for that patient for whatever reason. But it's not working. It's not healing. It's symptomatic. What are the reasons for the symptoms? Sometimes there might be other reasons, like periodontal around the tooth or whatever. But what I'm trying to say is I agree with Mark that you just sometimes just say, it's complex. You cannot give the patient answers. You simply don't know. Harold Messer, emeritus professor, used to sometimes go, we just simply don't know everything. Yeah. And we're just not going to understand the human body or why this tooth in the mouth, whatever that happened, didn't work. And you think you did it well, and you think you didn't see a crack, but there might be a crack. You just don't see the tooth in 3D, or it just didn't work. And yes, they had 4 others that worked, or had mediocre endo that worked. Yeah. So I think that's important.
Hard to predict sometimes.
That sometimes it's hard to predict, and so that's good that you pull out, and it's good that sometimes we also admit to not being God, and like you can't perform miracles every time. And then just in some patients, in some situations, we do give up and we sometimes don't understand why, and we wonder if there's an underlying element to it. Bruxism is one, TMD is the other, stress and everybody grinding, type A personalities living in Sydney, not in forests, all that kind of stuff. And at the end of the day, you do your best. This is what and I think this is what I'll have to quote. I think this is the person. Mark, correct me. Paul Fitzwalter. He quotes I quote him. He's obviously a very well-known and experienced endodontist. At the end of the day, you do your best, but remember, guys, the young guys out there, and this is to the newbie dentists, do the basics right. Yeah. Do the basics right, communicate well, and you're a lot less likely to go wrong. And us endodontists, we still do the basics right. I still have a very important diagnostic sieve from start. I always try not miss stuff. I have some pointers that I have in my little consent sheet, and Mark has seen. And then I try not to miss stuff. I try to spend more time assessing the case, and I don't always assess it in isolation. Yeah. Do you see what we see? And the answer is you'll see it with time. Yeah. So we might see more today than I saw 10 years ago, and I'm still learning. Mm-hmm. I still make mistakes, and this is all I want to say to the newbie dentists. I think you guys have a team. Don't forget that we're there. If you're in Melbourne or Sydney, or if you live in Dubbo, remember that we're still there. Just a phone call away if you get confused. And sometimes it's not our field. We'll tell you, no, this sounds like a TMD. Send to your TMD expert, or send to this or that or the other.
The one thing I want to quickly touch on before we just get on to talking about your courses and stuff coming up is in terms of diagnostics, specifically around like the pulp testing, cold testing. I find as a new grad, that's something that I really struggle with, because there's a huge variation of symptom. Either there's nothing, or then they're like hypersensitive, and then there are other teeth that like they respond and they're normal. So it's tough to kind of use that as like a barometer of like, okay, where are we at with the pulpal health? So and especially because, we're all in dental school in Melbourne Uni, we had like the actual CO2 sticks, so we're using those a little bit more consistently. Now a lot of the practice have like the endo frost and things. So you're not sure if is it the tooth not responding? Is my con pellet just like not cold enough? So if you have like just a few minutes, maybe each of you just like a little bit of advice about more predictable cold testing, that'd be like super valuable.
Yeah, so I guess I'll start, but I'm sure Mark will add to it, and he may also not. We look, there's different ways to skin a cat. I hope you're not a vegan or vegetarian. So I'll come up with a better job. But I'd say that I'll do it differently to Mark, and we're all clinicians, so you ask 10 people this question, and they'll probably do it slightly differently. One thing I know about pulp testing is that the colder the ice, we're talking about the the CO2 stick, let's say, style. Yeah. So the colder it is, the better. And where you put it on the tooth is important. So with crown margins, I always look for a bit of tooth or recession. I may put it on the palatal aspect, and I might also multiple test the same tooth from various aspects like buccal, palatal. So I do that routinely. The second thing is the colder the better. So endo frost, you said, what degree is it? It's -40. Yeah. So now we have endovit, which is Australian-made product, which I buy, which is -55 degrees.
And that's a spray as well?
That's a spray. So we're getting colder and colder, but remember that -72 is still better, especially in some circumstances where you really need a response and everything's, say, for example, calcified or it's got pulp, recession.
Yeah.
So I always go by ice test, or the colder the ice, the better. Yeah. And I always go by control teeth and what to expect in that patient. Because as you said correctly, hyper-response, some patient might be just hyper-responsive when you even probe them. Like you might do a normal periodontal probing, everything's healthy, but they just flinch and jump, right? So in that patient, you say, this is normal, perfectly healthy. Whereas another patient, you put ice on, they feel it, they just don't say anything, they don't even flinch. Yeah. So, but when you tell them, is it the gum or the tooth, they will tell you. And you want to put the ice on cervical margin, generally as a principle, and you want to put the electric pulp tester on the incisal edge, for example. Mm-hmm. So those are the minor variations. I only would use an electric pulp tester in young patients because of the undifferentiated A-delta fibers and the false positives you might get or false negatives you might get with ice. And I also use it in calcified canals. Yeah. I also would add that there is a test. I have a pulse oximeter in trauma cases where it's the ear size pulse oximeter. It's the Nalcor brand I get, which I can put around teeth and get a pulse, get a blood supply to the tooth, because we're talking here really neural supply. And neural supply in trauma cases or various cases where the patient's even a bruxer cannot be as good, but there could be still blood supply to the tooth. I also get the patient to tell me, and this is what I tell the patient, listen, patient, this is a very subjective test. I may treat the wrong tooth, or we might all get it wrong. So you are here right now to focus. I know you're in pain, or I know that you want me to just jump over this step, but this is the most important test of the lot for me. Often for the endodontist, we do all the other tests. We should walk the probe, for example. Yeah. We should transilluminate, right, to look for crack and craze lines. We should do all the other tests, but this is the one. Palpation, percussion aside is really the pulp test. So good point. Good question you asked. So I tell them, look, I'm doing this. I want to reproduce your chief complaint. So you're going to have to tell me, and I do a normal tooth. I say, I think this is a normal tooth. Okay. So quick, sharp, goes away quick. That's relatively normal. And then if something lingers, or if something comes on slow and leaves slow and lingers off and it gives you the intense discomfort that you experienced, then you're going to tell me. If you don't feel it and you're sure you don't feel it, it's, you put it on for a few seconds more and it's not from the gum, You don't feel anything from the tooth, and it's very different to the other, you tell me. And at the end of this particular process, I always tell them, look, if I'm uncertain, I tell them more. I look at top and bottom, and I say, could be this, could be that. I'm 70% sure it's this, 30% that. Do we wait? Time is on our side. You can go home, do a pain diary, come back, and I'll repeat the test. Or do you, no, doctor, I'm in agony. I'm pretty sure it's this tooth. I think this is it. Then I go, well, with your consent, with the test we did, which you took a part in, we're going to both treat this tooth. We're in it together.
Yeah.
So I think I don't know what Mark.
That's a good way of putting it.
So for me with the pulp testing, I mean, I don't like the sprays personally, even the -50. Mehdi knows this.
No, I agree.
CO2 is the gold standard when it comes to pulp testing because it's consistent every time you use it. When you are using spray, the temperature you hit the tooth with, each and every tooth is going to be different. Even
variable,
it's different. So you got to spray the pellet, put it on, spray the pellet, put it on. You can't go on. And when you got things like crown margins, trauma as well, the sprays just through personal experience just aren't as accurate. So really the only advice I can give is the CO2 tanks aren't that cheap. You buy them from Air Liquide. They come in, they give it to you. You can just get a builder or a carpenter to install it. It's really not that hard to put the setup in there. Really isn't that expensive. The expensive part is the actual little CO2 sticks. But they last forever, pretty much. So honestly, it's Mehdi mentioning using the reference teeth is very, very important. What I say to the patient is, what I want you to do when you feel something, I want you to lift your left hand. When it goes away, I want you to put your left hand down. And that tells you about the intensity and the duration of what it is that they're feeling. And you look for differences to normal. And if they jump out of the chair and throw a punch at you every single time, well, that's their normal. And you can maybe put it onto a tooth and 30 seconds later they start to feel it. So it's a delayed response like that. The other part is as well, patients will refuse pulp testing because they've had it done in the past. And if they refuse pulp testing, you refuse to treat them.
Yeah. Just
dig your heels in, just refuse. Because you can't treat what you can't diagnose. And if you're not going to pulp test, you're not diagnosing. So even if the patient says, and Mehdi and I can just disagree about this sometimes, if I'm uncertain, I need to be pretty much 100% certain before I pick up a drill, because I don't want to have that conversation with somebody that, well, we did this treatment and it wasn't necessary in the end. I like to be 100. So even if they're holding the side of their face in agony and saying, no, it's definitely this tooth, it's definitely this tooth, and I've done some testing and it turns out to me that tooth's responding within normal limits comparatively, I'm going to send them home. And they're going to hate me for it, but I'm going to send them home because, and I tell them, you're going to hate me a lot more if I drill the wrong tooth. And if they go, no, I won't. I go, yeah, you will. You're saying that now, but I know you will, because I've seen this in the past with other clinicians. They, how they feel at the time when they're in pain and thinking that you're going to fix it versus how they are later where it didn't fix it because pain. It's, unless I'm certain, I send the patient away and say, look, I've got to be certain. Let's wait. It's not going to kill you. It's going to hurt like hell, but it's not going to kill you. Because if they do have something that's going to kill them, like, And, you put them on analgesics, anti-inflammatories. So a lot of the time they're saying, I'm taking endo, and I'm taking Percocet, I'm taking whatever. Over-the-counter Nurofen works really well. It's an anti-inflammatory, and those severe toothache pains are due to inflammatory pain. So they need an anti-inflammatory more than they need to have opioids and Panadine Forte. Same as if they're, if a patient's clamoring for antibiotics, but it's obviously an inflammatory pain, you just got to say no to them. Doesn't matter if they say that you're the worst dentist on earth. I get tons of patients coming in to me. This is on a weekly basis saying to me, my dentist is terrible because I was in pain and he didn't give me antibiotics. And I'm like, yeah, but you don't need antibiotics. Sometimes the patient's going to be angry about something that to them they have a right to be angry about, but to you, they really, it's in their best interest. So their pulp testing and diagnosis is part of that as well. There isn't a whole lot of fancy stuff when it comes to diagnosis, really, and pulp testing. It's really it. I mean, electric pulp testing I only bring out if the pulp's calcified. Otherwise, I don't touch it at all. especially in elderly patients. I mean, EPT is a lot more accurate, I've found, in elderly patients. There's some patients when you try and communicate with them what you want from a pulp tester, so, raise your hand, put it down, and they just don't get it. They'll say, but I didn't feel pain. Did you feel cold? Yes, I felt cold. Okay. So you put the electric pulp tester on them, and that's a lot more accurate in that case, because they will feel it.
It hurts, yeah.
They feel a sting. It's, they hate you for it, but they feel it. And the other part is when you tell them to raise their hand, make sure they raise the hand that isn't the one closest to you, because I have been hit. I don't let little old ladies keep their purses on their laps. Yeah. I have been hit like a hammer throw, pulp a patient. But yeah, that's really it.
Yeah, so just like I said, just have a good systemized way of doing it. Try and do it the same way every time. Yeah. I've heard, and you guys just reaffirmed that having the spray is probably not the best, most predictable way, just because the temperature drops and it's not. So that's why I think that a lot of that variability that I'm experiencing comes probably from using the spray versus using the CO2. So to wrap things up, guys, obviously you're both really involved with teaching, and I came to your course that you guys had on like about 2-3 weeks ago. So tell me a little bit about the teaching side of things. I know it's something that you guys are both kind of passionate about, and honestly, from a side, you guys are really good at it as well. I learned a lot from you guys and the hands-on components and the tips and tricks that you passed along to us. So tell me a little bit about what's on the horizon the next few months, next little bit. And I'm definitely, like I said, I'll post them in the show notes as well for the listeners if they're interested in checking them out.
Sure. So which course did you actually do? I can't remember. Sorry.
It was the Kerr. It was like the one that was by Kerr,
okay.
TF adaptive system.
Yeah. So we call that one the entree before the main. So that's sort of a basic course for the newbie dentist, is probably highly recommended. So the one-day courses we run around Australia probably cover the basics, and still lots of tips and tricks, and you get to watch a lot. But in terms of hands-on, it's not as hands-on as the advanced courses we run at the ADA New South Wales. We call it advanced contemporary endodontics, not advanced endodontics, because there are two different names and they run both courses. So it's advanced contemporary endodontics. If you guys are interested, look for Mark Johnson, myself, and often you'll find there's also Dr. Shankar Saturn or Jeff Young part of that as well. So they're very good courses, because if you've done basic courses, you've sort of been using rotaries for a while, you may be able to touch on that, learn a few different instrumentation techniques, like to be up-to-date instruments from different companies. And it is the course where we don't get driven by a company to teach you, because there's only one product there from one company. So it's all the different companies, and they all give you different equipment. And it's also the course where we can teach you a little bit on retreatment, the philosophies of how we retreat, give you a little bit of hands-on on it. Post removal, for example, the different types of posts that we have. And we do touch on, fractured instrument removal, not to come out of that course without a microscope. Everybody starts to remove instruments. We don't do that. We don't, we're not cowboy dentists, and I'm not going to teach you guys cowboy. Like a lot of times, the principles, how it's done, when it's done and how we assess it. But at the end of the day, we want you guys to leave that with a better clinician. And also, according to what people say, you definitely doing the advanced course will know a lot more about the MB2. Like, you know exactly where to look for and what tools to use to look for it. And you're more predictable at finding or calcified canals, basically, and how to manage those. I think that's the courses, Advanced Contemporary Endodontics. We do run a long course. So this is the only long course that I'm aware of in Australasia. So you can go to King's College of London. It's sort of the similar type of course. They call it the Masters in Endodontics, but this is called Mini Residency Endodontics. Unfortunately, at this point in time, until people come up with other courses, it's really difficult to get into that course. We have a long wait list, but then again, people do pull out. So if you're interested, contact the ADA New South Wales. I love the guy called Jeff Coe. He's a general dentist, he's got multiple practices in Brisbane. So we love running courses with him. So we do advanced endodontics around Australia. The next one coming up, I think, correct me if I'm wrong, Mark, 26th, 27th of October.
Okay, so October 26th, October 27 in Cairns.
Yes, it's sort of like a tax deductible, we're at James Cook Uni there. It's a very good facility to run hands-on courses, and we give you guys a bit more hands-on than, say, the Kirk course you came to, Amit. So hopefully we get to see you in Cairns. We can go dipping in the pool and go to the Green Island or whatever and do some snorkeling. So we do like those type of things. And I think next year we've got Queenstown coming up. So if you're keen on skiing, well, in July somewhere, we'll go with Mark Evans, Professor Mark Evans, myself, and Mark Johnson to Queenstown, and we'd run a similar type of course, Advanced Endodontics. Apart from that, really, I'm involved at the ASC level. So I hope you don't mind me. I'm just sort of
for sure.
The root cause has caused a lot of anxiety.
Yeah.
So the title is Root Cause, It's Pulp Fiction, exclamation mark. And September 3rd, 7 p.m. Eastern time, 7 p.m. Sydney time. We're there with Professor Laurie Walsh, microbiologist and dentist that everybody knows. At the college level, myself, Professor Mortaza Afmeshev, an oncologist, professor and teacher at Wollongong University. Benson Riddle is a general practitioner, medical, and he's going to debug the meridians. So this whole thing about a tooth being related to something around the body and cancers and all that. And we also have Brett Gilbert, the endodontist from the US, and Peter Norton, who's a dentist that I think a lot of people know.
It's a good panel.
It's a panel discussion, but we do have expert opinion from various professors from different countries, mainly US-based and Australia-based, so they make statements on the root cause. And I think it's a really good teaching tool from the young dentist side and all dentists, because you guys do more endo than we do. 75% of all the endo is done by you guys. When patients challenge you, then at least instead of having a yarn and spending time and then still they sit on the fence, the ones that are not completely on the fence, they're sort of in between, you can just direct them to this YouTube clip eventually. But if you want to ask questions, we'll go live. So it's live.ascnsw.org.au. So that at 7 p.m. that time, if anyone's interested to come to it, then please come and listen to Professor Turbinizad. You're probably the hands-on courses for endodontists, postgrads, and oral surgeons and all that. Yeah. But come and listen to him for 4 hours CPD, 3.5 hours or so of his talk on Saturday morning from about 8 a.m. to about 12 p.m. Again in Sydney, 21st of September. And I can share, if you like, the info for that. I think I already have shared.
Yeah, for sure.
He discusses extract or not extract. He discusses why do we still do surgery. He's just written his latest textbook on endodontic surgery, microsurgery, with Richard Rubenstein, one of the gurus in endodontic surgery. But he does discuss his patient factors and implant prognoses, and he's done stuff with Goodacre. So it's pretty cool. Like he's an overall perspective on treatment planning, really. So if you're interested in multidisciplinary treatment planning, come listen to Professor Turbinizad, 21st of September. That's all I've got to cover. I don't know, Mark, add to it.
Yeah, plug in the pluggables. So we've got one more revealing the endodontist secrets for Kerr on September 7th in Intercontinental Double Bay in Sydney, which I get to stay overnight at, which is great because it's an awesome hotel and they've got a really nice breakfast buffet. Mehdi mentioned we got October 26, 27 in Cairns, doing the 2-day lectures and hands-on. I'm doing a one-day thing of lectures with a little bit of like an hour hands-on at the end of the day for Young Dentist Hub on October 11.
Oh, yeah, nice.
So the theme of the day is going to be about endodontic complications, which should be great fun to talk about. November 23, Mehdi and I are going to be in WA at Perth for the ADA Western Australia, doing a one-day lectures and hands-on program, pretty much start to finish of an endo. Again, nice.
We do MB2.
Entry-level stuff.
And we've got
MB2 as well. And Mehdi mentioned about the Advanced Contemporary Endo Part 1 in ADA New South Wales. So it's booked out this year, obviously, but next year there's March and November if you want to sign up for that in advance. And we're also possibly having a lecturer from Japan coming in March to Sydney named Taruchi, and he's sort of like, if you had a person that was better at removing instruments on the planet, you'd probably be hard pressed to find someone other than this guy. Like this is a guy that endodontists listen to, so it's going to be really cool having him out. I'm not involved in lecturing at it. Mehdi's not involved in lecturing at it, but that's just something really cool that I don't know if it's going to be open for general dentists to be involved.
It is. Okay, it is. The lecture, the hour and a half.
There's an hour and a half. There's a lecture part of it that's going to be open to general dentists, which I think would be really cool to go and listen to.
Yeah, that'd be awesome.
Because I plan on going to it just as a, to listen, because this guy's got a very good reputation.
And if you've done advanced courses and you've proven, you can attend his hands-on course, but that's by a special selection. So if endodontists and postgrads don't fill up the room, then possibly advanced course. Many residency in endodontics, for sure, because you've done a long course, you could qualify for doing his hands-on on instrument removal. The last one is I forgot about the Young Dentist Hub next week. So next week I'm in Brisbane on Sunday doing a one-day course on, again, the hands-on will be prep obturate, similar to the Kerr one you did. And the addition is we've got 3 scopes and we'll be discussing MB2 at detail, and we'll be using instruments and a special technique at locating it. That's next week, Sunday. Young Dentist.
Awesome, busy.
I forgot, because of course we do so much lecturing, you forget.
I just forget stuff.
I'm doing so I lecture with Boss Orthodontics with Vandana. So I'll be lecturing on February 16th for that next year as well, as part of their orthodontic program, which should be good fun too.
Awesome. So make sure I know, Mehdi, you sent me a few things already. If there's anything else, let me know. I'll put it in the show notes for anyone listening who's interested in attending some of these courses. They can check it out, get some more information, and definitely attend. From the entrepreneurial side of things, I love that you guys are doing all this stuff, and the little side hustles outside of your day-to-day clinical is what keeps it fun and keeps you
it does
things exciting, right? So I definitely have a lot of respect for that. And guys, thank you so much. I know we went a little bit over the time I kind of promised you, but a lot of valuable content, a lot of useful tips and tricks and like phrases and mindset stuff that I think a lot of people listening, new grads or even anyone who's been out for a few years, can really benefit from it. So thanks again for coming by and sharing some information.
Thank you so much for inviting myself and of course on behalf of Mark as well. And remember that I love being social. So I'm on Facebook. I'm addicted to it now. I'm Insta and I go live. Okay. So the reality is, what I'm trying to say is, if those newbie dentists are watching, and we're very open to communication. So if you're wherever you are in Australia or outside Australia, if you're listening, just communicate with us. We love seeing what you guys do, and we'll gauge where you're at, and we can always mentor you through it. The more people I communicate with, the better. I'm a very social, the social endodontist.
Yes, thank you so much for coming on this episode, guys. It was amazing. A lot of great content that we covered up. I know before we wrapped up, you wanted to just have a quick disclaimer as well, just based on your affiliations with certain brands. So go ahead and do that if you want to do that now.
Yeah, Mark, you do it. Yeah.
My name is Mark Johnstone. I'm an endodontist working out of Maribyrnong, Victoria, and in Chatswood, New South Wales. I am a KOL for Kerr. I get paid to lecture for Kerr Endodontics, but I have no financial or vested interest in any of the products or services discussed when I talk about endodontics.
And my turn. My name is Mehdi Rahimi. I'm an endodontist in Sydney, and I lecture. I'm a KOL for Kerr, Ultradent, and Action. Bear in mind, when I'm discussing, I have no invested interest in any product I'm discussing. I'm just here to tell you what I use and what I do. And I make no investment or no invested interest in any of the products I might discuss, in case I mention one of these products during the discussions.